Hi, my name's Nancy Poole, and I'm the director of the Center of Excellence for Women's Health and the prevention lead for the CanFASD research network in Canada. And this is to introduce you to a series of presentations about research on FASD prevention. So this series shares brief explanations of what we know about FASD prevention from those who are currently conducting research from a number of countries. And the goal is really to make this research accessible and to inspire people to take up the findings in both practice and policy. So you can see we have 5 sections in this series, starting with presentations about stigma as a central issue in preventing FASD, then offering some frameworks for FASD prevention, then looking at what we call level 1 prevention in Canada, which includes broad awareness raising, health literacy, and community-led health promotion efforts. Then looking at what we call level 2 prevention in Canada, which is brief alcohol interventions plus integrated support and referral as needed with all women. And finally, levels 3 and 4 prevention, which is about engaging and assisting pregnant women who use alcohol or are trying not to, and who face related health and social concerns. It also involves supporting new mothers and their children to build on the gains they've made to reduce or stop drinking in pregnancy, to support them to improve their health and their social status, to support attachment and promote assessment of children's health. In this section, we look at studies in 3 countries about awareness raising and really linking awareness raising about FASD as a disability with the risks of alcohol use in pregnancy. And we hear about grounding awareness building in communication theory, conducting and evaluating a national awareness campaign, and integrating awareness raising with a protocol or framework for Indigenous health.
Greetings from New Zealand. Thank you for the opportunity to be part of this important seminar series. My name is Mathew Parackal, and my co-author is Shirley Parackal. Our work is mostly centered on health communication. And in this presentation, I'd like to share one of our studies in which we developed a strategy to communicate precisely what the title says, how to tell women not to drink. It appears to be very simple and straightforward, but those of us who've been in this game know it's not easy when we want to tell women this message at a public level. The study was published in the Health Promotion International, so the full paper is available at this journal website. I'll start by explaining a fundamental difference in the way we communicate. We have been using the traditional one-way communication based on Shandiin and Weaver's model. In this model, we send message through a mass media channel to a target audience, and the assumption is the audience would decode the content and make sense of the message. And this is the way marketers have been communicating for decades. But now with the establishment of digital technology, we have channels that facilitate two-way communication. In this form of communication, we can have one-to-one, one-to-many, many-to-one, different formats of communication is possible. So we shifted from a monologue type of communication to a dialogue, and that's a big difference. And infrastructure in terms of the expertise and knowledge that is needed in order to hold a dialogue at a market level is much more higher than what we used to have traditionally with the one-way communication. Now, in this digital landscape, developing communication strategy requires us to rethink the way we look at things. So there's a fundamental shift in our mindset that is essential. So that is key to being effective in communication in this time. And then we also need to find theories that are relevant and suitable to use in this kind of mindset that we are currently in. So let me talk you through these two aspects. First, the mindset. We're shifting from what we normally refer to or call as product orientation to service orientation. And we believe that service is the dominant logic in the current digital environment that we are operating. There are many things, but I want to just highlight four in relationship with communication. One is, in this mindset, marketing is done with customers and not to customers. And this gives us the opportunity to co-create value that is meaningful for all the parties involved. Now, what we are really exchanging, when you think about, is the value that we are interested in. And we are able to derive that value for each stakeholders involved in the transaction. But the interesting thing about value is that it is defined by the end user. We cannot impose our value on customers. The customer defines the value. The customer decides whether the value is meaningful to them or not. We also need to understand the amount of value derived depends on your skill sets and your knowledge. So keeping these four factors in mind is important for us to develop communication strategy at a public level. So within the SD logic mindset, transaction is in the form of exchanging values. So the best we can do from a marketing point is to propose values. And if the values are appealing, interesting to customers and individuals in the target market, they would engage with us. We can then apply some marketing to enhance the engagement and also to maximize the value they derive from our exchange. So while it may seem that what we can do is restricted, because we use value as the unit of exchange, it becomes very powerful in achieving our end goals that we have set for ourselves. From a communication perspective, there are just two roles. One is to educate users to enhance the value that they are deriving. And the second is to direct them to information sources. So in the context of this new mindset, we identified two theories that could provide us the framework to develop a communication model. I'll talk you through both of them. The dynamic transactional model of communication is one that we have quite extensively worked here at Otago University. So the first theory is the media complementarity. According to this theory, traditional and new media are able to coexist. And this is true in pretty much all markets, and we can see this all around ourselves. We consume news from the newspaper as well as from social media and blogs. And we use a multiple source to corroborate the information that we have collected. So because we access and use multiple sources, these traditional and new media are continuing to exist, and they together provide us multiple media channel that we can effectively use to communicate message at an aggregate level. Based on the way we use these media, we can broadly classify them into monitoring media and search media. The monitoring media comprises mostly the one-way channels, and we can use this to disseminate stimuli. A good example is the news which we watch at the end of the day, and in between the news we see these ads and then access the website on our mobile phone or tablet. So the search media are those media which contain in-depth information that is available for people to access. So sources like library databases, journals, and websites and blogs. So based on the way we use it, we can categorize it into these two types of media, which can then be used appropriately in developing our model. The next theory is dynamic transactional model of communication. This is not a new theory. It exists in all interpersonal communication. The establishment of digital channel allows us to apply this type of theory at a public or aggregate level, which is interesting for us. A few things that are quite cardinal to this theory. One is it is observed in all two-way communication. The second is all parties involved are senders and receivers. And that makes communication quite complex and difficult to manage, unlike the traditional communication, which is very unidirectional. According to this theory, individuals explore and learn about themselves by responding to stimuli, which is interesting, which allows us to initiate conversation with a target audience. And finally, we all agree to this, that we are all learners, continuous learning at both the sender and receiver's end. So with that background, I'd like to briefly talk you through research that we did to recommend a media strategy for communicating alcohol-related message to New Zealand women of childbearing age. It was a national survey and it was done in two parts. The first part, we identified the media options available to women of childbearing age. So this was achieved through in-depth interviews. We spoke to 15 individuals to find out all the media options that are available to them. So this study identified 13 sources which were then applied in quantitative survey research, which allowed us to identify or define the media mix. So the 13 sources were developed into Likert scales on which preference ratings were collected. The items were included in a national survey of New Zealand women between 16 and 40. We implemented this through a telephone survey, and we obtained a response rate of 65%. So the 13 items were analyzed using principal component analysis, where we reduced them into 4 categories: conventional media, electronic media, healthcare service, and public service. So this provided us the categories into which those media channels could be classified. We then rank ordered the categories based on their aggregate mean of all the items within each of their category. And what we have as the rank order is, first on the list is healthcare services, followed by electronic, conventional, and public service. We can now, based on the rank order, organize them into a model based on the two theories that I covered previously. So this is how our model looks like. We start with the monitoring media, made up of the conventional category, which has television ad, radio ads, radio programs, television programs, and so on. So we use these media to distribute stimuli to the target population. Now, if our assumption about ourselves is true, that we respond to stimuli to discover, to learn about ourselves, we would expect people to respond to the stimuli and move into the search media categories. And here we have healthcare services, electronic media, and public services. And as people engage with these categories, we can expect that the right knowledge and information gets transferred into the target population, which leads to behavioral and attitudinal change. I hope this model inspires some of you all, and if anyone is keen to know more, get in touch with me. I'm most happy to help and share some of the things that we have been doing here in New Zealand. Thank you very much for listening, and I wish you well.
Hi, everyone, and welcome. My name is Victoria Bailey. I am the Communications Manager with the Canada FASD Research Network, and I'm here today to talk to you about our ThinkFASD campaign, and that is a national FASD prevention campaign that was held in Canada. And this campaign came about as a result of the COVID-19 pandemic. So early on, FASD experts were really worried about the impact COVID-19 would have on FASD. So we were hearing that supports and services that families were relying on were closed down, that people with FASD who had set routines, those routines were being thrown in disarray, and the uncertainty was causing increased levels of stress and anxiety. We were also concerned about the impact that COVID-19 might have on alcohol-exposed pregnancies. So a little bit of background, this concern was compounded when the Canadian Centre for Substance Use and Addiction published the results of a survey early on that stated that alcohol consumption in Canada had increased as a result of the pandemic. People were drinking more often, and they were drinking more than the recommendations in the Canadian drinking guidelines. The survey also stated that people were drinking due to stress, anxiety, and boredom. Then there was the lack of supports and services as things closed down due to the pandemic, a potential increase in mental health challenges as people are more isolated and they have less access to those supports and services, and potential for people to be using alcohol as a coping strategy to deal with these other issues. And these issues are all factors that could contribute to increased rates of alcohol-exposed pregnancies and increased rates of FASD. So we got funding from the Public Health Agency of Canada to run a prevention campaign focused on raising awareness of the risks of drinking alcohol during both the preconception and perinatal phase. And this was actually the first ever national FASD campaign of its type in Canada. So we wanted to target people who are at risk for alcohol-exposed pregnancies. And we found that those could kind of be broken down into three separate groups. One, people who are pregnant, two, couples who are trying to get pregnant, and three, couples who are having unprotected sex. And it's important to note that we targeted couples in this campaign, and that was to reduce the stigma and responsibility that's often placed on women surrounding FASD prevention. We know that to support healthy pregnancies, it's important for partners to go alcohol-free as well, and we really wanted to reflect that in this campaign. So we chose to use the messaging "drinking and baby making don't mix." And there were many behind the scenes conversations that led to this message. And there's pros and cons to using this type of language. but we ultimately chose it because we thought that baby making was kind of an eye-catching phrase. It's not traditionally used, but it typically refers to sex, but it could also be taken literally to mean making a baby. So it kind of worked with all three of those target audiences. But the messaging didn't necessarily resonate with all of our followers, which I'll talk about a little bit later. From a visual standpoint, we had some specific criteria that we really wanted to meet. So one, we wanted to show both men and women to, again, highlight the importance of the couples being engaged in FASD prevention. Two, we wanted our ads to reach all of our target audiences. So we kind of rotated in pictures from each of those target groups. So couples who are pregnant, couples who are trying to get pregnant, and then couples who are having that unprotected sex. We avoided only using pictures of very pregnant women because we wanted to represent women at all stages in pregnancy, to highlight that FASD prevention is important at all stages in pregnancy. And then we wanted to also provide people with options for a representation of people engaging in healthy behaviors. So we have pictures of people drinking tea, like in the pink ad, rather than drinking alcohol. And then we chose black and white for the photos to kind of match with that old-timiness of the phrase drinking and baby making. We had color underneath the messaging to make the messaging pop and make that a little bit more colorful and playful. And then we had a silhouette in each of the ads that represents either a pregnant belly, like the pink and yellow ad, a beer bottle like the purple and orange ad, or a wine glass like the teal and blue ad. So campaign launch consisted of a media release, a website, Facebook ads, and YouTube ads. So this was our media release. We put it out on a news release distribution site, which was expensive, but in the end was really helpful to get it out to a wider group of people and let people know that this campaign was launching. We had a specific microsite for our campaign called ThinkFASD.ca. A microsite is basically a really small web page that people can go to that generally just gives information about one specific topic or one specific event. So in this case, it was this campaign. So on our site, we had a main page with a general overview of what FASD is. And then we had other pages that broke specific information and resources down for each of our target audiences. So those who are pregnant, those who are trying to get pregnant, and those who are having unprotected sex. And our ads that I'm going to talk about in a second drove people to this microsite to get that more information. So we developed, like I showed you before, those were the ads that we developed for Facebook. And they shared that message, drinking and baby making don't mix, and sent people to that microsite that I just showed you. Our ads on Facebook were targeted towards men and women aged 18 to 44, but it was slightly skewed a little bit more towards the younger age group. And they targeted 10 major cities across Canada to try and kind of get a whole national representation. So Toronto, Montreal, Vancouver, Calgary, Ottawa, Winnipeg, Saskatoon, Halifax, Moncton, and Yellowknife. And these were our YouTube ads. Each of them ran for either 15 seconds or 6 seconds. The first one, so that purple one, was targeted to pregnant couples. So it showed a couple on a couch drinking orange juice, and the woman is visibly pregnant. And then the second one targets that kind of unprotected sex crowd, trying to get pregnant crowd. And it was a couple just on a bed. So the results of this performance, overall, the ads themselves saw almost 2 million impressions, which is the number of times the ads were seen, and over 800,000 people actually saw those ads out of those 2 million impressions. Some people might have seen them multiple times. Of that, over 1% were actually engaging with the ad and going to the microsite. 1% doesn't seem like a lot of people, but in the marketing world, especially for awareness campaigns like that, 1% is actually not bad. It's pretty good. The Facebook ads accounted for the most of those impressions with 1.2 million and 450,000 people reached. 450,000 people reached. There were 1,300 clicks on the ad from Facebook. On YouTube, we saw over 700,000 impressions and 409,000 actual views. The alcohol and pregnancy one did the best. It had about 360,000 views versus 250,000 views on the unprotected sex awareness videos. What's interesting is that with the YouTube ads, people weren't really skipping through. So usually YouTube gives you the opportunity to skip through an ad to, after a few seconds to actually get to the video you were originally searching for and originally clicked on. But many people we found were actually watching the whole video, which was really interesting. So it's clear that messaging was engaging them in some way. So over 15,000 people actually saw the ads and went to the webpage to get more information. On average, they didn't spend a ton of time on the page. It was about 20 seconds per person. But they often click through the page more than once. So that was about 1.3 sessions per page, which isn't bad for a microsite considering this site really only has 4 pages associated with it, the main page, and then those 3 other ones where you can get more information. And then finally, our news release. This was probably our biggest win. It was picked up and published by 132 publications across Canada, and that includes blogs, newspapers, online news publications, all of those. And the estimated audience of that release alone was over 7.6 million people. So that was huge for us. In terms of future steps on this campaign, like I said, the messaging didn't necessarily resonate with everyone. So these were some of the comments that we were getting on Facebook underneath our ads. So pretty sure that 90% of babies are conceived using this message. Isn't this how all babies come? This was how my son was conceived. My son told me, or my mom told me that I'm the product of a drunk shower bang. So these messages were kind of showing that people weren't necessarily getting or making the leap between alcohol, unprotected sex, and potentially unplanned pregnancies. So they're kind of focusing on the alcohol and unprotected sex piece and weren't necessarily making the leap about how that could potentially result in an unplanned and alcohol exposed pregnancy. So ideally next time I'd like to narrow our audience down a little more and maybe kind of parse these 2 audiences out from preconception and perinatal. And ideally I'd like to actually measure what people thought about the campaign and see if it's actually helping to reduce alcohol exposed pregnancies. So that would be there'd be great opportunity to do kind of an evaluation to see whether the messaging actually aligned with a change in behavior. But here are the final details. If you want to learn more about the website or see it in person, you can check it out at www.thinkfasd.ca. Our website is CanFASD.ca. You can also check that out for more information on FASD research in Canada. And if you have any questions about this campaign, we did learn a lot and we'd be happy to share what we learned. So feel free to reach out to us at info@canfasd.ca and we can connect to talk about potential of further campaigns in your area. So thank you so much for listening and enjoy the rest of your day.
Welcome everyone to our presentation on FASD prevention in a reservation-based Indigenous community. My name is Shandiin Armao. I am from the Navajo Nation and I am a research assistant on this project.
Hi, my name's Rhonda Romero. I am a local tribal community member, research assistant, and community liaison.
And hi, I'm Annika Montag and working at UCSD Department of Pediatrics.
We have nothing to disclose today for this presentation, and I wanted to welcome you to Indian Country and Healthy Native Nation. These pictures are here to give you a sense of the desert geography of our region that greatly influences the tribal culture, traditions, and ceremonies. The tribes in this area remain active in their bird singing, peon games, and other cultural activities and ceremonies. We are Healthy Native Nation. And we are here to increase awareness, provide advocacy and support for families affected by FASD, and to improve and strengthen the lives of individuals with FASD. We are also proud to be the first tribal/reservation-based NoFast or FASD United affiliate. And one of the main ways we are aiming to provide this support is through the Healthy Native Nation Family Support Program. Our aim with this program is to determine how to best help and support families dealing with developmental disabilities and delays, and to create culturally congruent, meaningful, impactful, family and community-specific support. We believe greatly that prevention is raising awareness and increasing education in the community. In order to do this, we put a lot of effort into training our clinic staff, educators, and professional groups throughout the community. We partner with FAS United and have held 2 Warrior Women conferences with them for women in recovery. We have facilitated trainings for teachers and staff, along with a workshop called FASD in the Classroom at local schools. And we've also collaborated with tribal courts and tribal law in the area and have held a conference with them called FASD and the Law. We are really proud of all this work we've done, and it doesn't even include the many conferences and workshops that we have held in person before the pandemic and the many, many cultural gatherings that we attended then and will continue to attend.
Support prioritized by our community has been educating providers with dealing with the community, educating the community, having a support group, adopting a cultural focus, educating families and connecting them to resources and existing care, access to diagnosis, culturally congruent child care and respite care, advocates from within the community. Social media messages from 9/9 FASD International Awareness Day. Additionally, for September 9th, International FASD Awareness Day, we have created these educational posts for our clinic social media. We also have held community art contests with speakers and fun receptions pre-pandemic. 9/9 is a big deal in our area. What we have done to reinforce our message and support in the community. Our clinic's community newsletter, Healthy Native Nation Resource Library, Talking Circle Support Group, Community Resource Guide, and Community Liaison. Our clinic's community newsletter keeps our community up to date on Healthy Native Nation activities. Our Healthy Native Nation Resource Library has books, brochures, flyers, and a community resource guide. We also provide one-on-one trainings. Our Talking Circle support group pre-pandemic was in person. Now we have a support group email that goes out bi-weekly. It includes topics like ideas to take care of your body, ideas to take care of your mind and spirit, tips and activities to be there for your child, activities to do for fun together, a healthy cooking recipe, and always a cultural story. Our community resource guide was created to provide extensive list of local resources and information on FASD. My role as a community liaison is to communicate families' needs to the clinic staff and assist with medical appointments and notes when needed. Networking with our OB clinic. Healthy Native Nation has partnered with OB Clinic to reach our Native women. In order to reach the moms, we have created a developmental chart for all exam rooms in our clinic at 2 sites. We have also shared our pregnancy chart with other local tribes. We give out gift bags monthly to the moms-to-be, and we have designed multiple educational brochures we include in these gift bags, along with a small gift for the mom.
There's deep creativity and artistic talent in our community. We're fortunate to be able to use art from local Native artists in our material. The art resonates with the community, and the artists really enjoy helping us create beautiful, meaningful pieces of art. We were funded by FASD United, formerly NoFAS, to create these 2 videos. We've used them to raise awareness of the importance of having an alcohol-free pregnancy. And you can find them on YouTube and FASD United website. And we would like to acknowledge the funders that have enabled this research, the community members who support us and generously allow us to benefit from their knowledge and their brilliance, and the families and individuals with FASD who inspire and motivate us. Thank you.
Some reflections on this research about approaches to raising awareness and doing community level prevention work. And Dr. Parackal discussed how complex it is to effectively communicate to and with women, and how theories can guide us as to how to communicate through multiple media channels and using two-way community strategies. Then, the ThinkFASD campaign and its evaluation considered if in awareness campaigns we can effectively reach all 3 of the groups they were targeting for FASD prevention messages: couples planning a pregnancy, couples having unprotected sex, and couples when pregnant. So adds a lot of challenges to thinking about the audiences and the various things that will be connective and important for each of those audiences. And then in Indigenous contexts, the Healthy Native Nation group has implemented and studied a really wide array of education and awareness raising activities in an American Indian community over time. And whether it's a newsletter or all the way to linkage with their OB clinic, they've really considered how to do community-wide, community-led FASD prevention and support. So all 3, whether it's the communications theory, the different audiences, the community-led approaches, I think really inspire us to think about this critically important and perhaps foundational level work on FASD prevention, foundational to all the other levels of prevention. And this research doesn't touch on the many areas of awareness building and community development that are relevant to FASD prevention, and just wanted to mention how important health literacy materials, low-risk drinking guidelines, and warning labels are, as well as some of the methods that have been presented here. And if you're interested in discussing the implications for practice and policy, you're welcome to contact the researchers and or us at the CanFASD Research Network.